Our next speaker is Prof. Zolf Mughal. Prof. Zolf Mughal was graduated in medicine from the University of Liverpool. Then he received his postgraduate training in pediatrics hospital in Manchester in Liverpool. His main interest in bone and bone mineral disease in children. He has more than 150 published peer-reviewed scientific papers. He have two talks today with us. The first one is about DEXA scan in children, make sense of DEXA scan in children.
Good morning, Chairs. And I'd like to thank the organizing committee for inviting me. It's always a pleasure to come to Palestine. Dr. Sabah has very kindly given a very nice talk about the appropriate use of DEXA in the right clinical context in an adult with diabetes. And I know that you've acquired a new DEXA machine and you're planning on using it for pediatric patients. So I thought I might just talk about our experience, the way we use DEXA in children, because it has its own unique challenges, and I don't think you can just put a child in the DEXA machine, get the results out and use it in clinical practice without sort of making appropriate adjustments to the data. So the outline of my talk is, why measure bone mineral density in children, and I'm going to talk a little bit about DEXA. I'm going to talk about the International Society of Clinical Densitometry pediatric position on osteoporosis in children, and illustrate the use of DEXA in a couple of clinical cases. Osteoporosis is a common problem in adults. If we live long enough, we will develop osteoporosis. But there are many childhood conditions which are associated with low bone mass and increased risk of fractures. For example, the inherited bone disorders such as osteogenesis imperfecta and oral corticosteroids, which are being used to treat a number of different conditions. Even in the biologic era, we still have to use steroids. Chronic inflammatory disorders all cause reduced bone formation and increased bone resorption. And then there are other chronic illnesses like cystic fibrosis. Neuromuscular problems affect the whole geometry of the bone and cause bones to be very narrow and slender, causing them to break. And then there is primary and secondary hypogonadism. And you may have some or combination of these factors which affect children. And so it's important that we assess their bone health. International Society of Clinical Densitometry pediatric position. I was involved in the 2013 guidelines that were developed, and they've recently been updated. But the important thing is that what Dr. Sabah mentioned about diagnosis of osteopenia and osteoporosis in adults cannot be used in children. Particularly if you're looking at T-score, you're comparing the bone mineral density value of an individual with peak bone mass, which is the total amount, the maximum amount of bone which is going to be accrued in a young healthy person. So in a lady by the age of around about sort of between 24 and 26, and men between around by the age of 25 and 30 years. So in a child, this would be comparing a height of a child with the height of an adult. So you cannot use T-scores in children at all. You have to use Z-scores which are appropriate for sex and gender. So the International Study of Clinical Densitometry guidelines says the diagnosis of osteoporosis in children and adolescents should not be based on densitometry criteria alone. And if you have one or more vertebral compression fractures with loss of height of a vertebral body of more than 20%, it's an indication for osteoporosis regardless of your bone density values. And then the diagnosis of osteoporosis requires both a significant fracture history and low bone mineral content or density, which is adjusted for age, gender, and body size. And the significant fracture history in a child is 2 or more long bone fractures by the age of 10 years or 3 or more long bone fractures by the age of 19 years. So totally different definition from that used in adults. And a lot of emphasis is based on vertebral fractures, and as I'll show that we actually now formally look for vertebral fractures in our children who are at increased risk of fractures. So, what determines bone strength? So here you have cortical bone, which is a cross-section of a tibia, and here you have trabecular bone, which is taken from the spine. About 80% of the bone is cortical bone in our bodies, and about 20% is spine, is trabecular bone. If you want to really look at the strength of the bone, you need to be able to measure the size of the bone. So the long bones, for them to be strong, need to be wide. So size is important. And then you want to be able to measure the amount of mineral that's contained within the bone envelope, or its density. And you need to be able to look at the fatigue damage, which we are not able to do so in vivo. But we can measure the size by DEXA, we can measure the content, and we can sometimes measure the shape as well. So what is DEXA? DEXA is basically a machine which produces two sources of low energy which traverse through the body, and the attenuation of these beams allows the machine to actually estimate. It's really like a scale which can fractionate the area which is studied into fat mass, into lean body mass, and also into bone. So you get more than just bone data from this, and lean body mass is an important surrogate for muscle, and I think that's quite important. So here you see one of our study patients having DEXA, and this is for the lumbar spine, and you can see the lumbar spine images appearing on the old-fashioned screen, which is quite an old slide. DEXA was developed for adults. Children are not small adults, and you need to have normative data for children, and ideally you need normative data for your particular area or region. Just as you cannot use American growth standards for in the United Kingdom, we have to have our own growth standards. Similarly, I think for the Middle Eastern countries, you really need to develop your own reference values, because DEXA data is affected by growth parameters. So we actually set up, we had a mobile osteoporosis van, and we went to schools and measured about 800 children and devised our own normative data. And then about a few years ago, we actually sort of combined all these sort of normative data from all the UK sites and published very sort of robust document with more than 3,500 children for bone density data in UK children, both for the Hologic machine and the GE Luna machine, which are the two companies which make these two DEXA machines. They use completely different algorithms for data acquisition, and therefore you can't measure the bone density in one machine and use the data from another machine to interpret it. So you need a separate normative data which is machine specific. So it's gender, size, machine. So why is DEXA such a challenge in children? Well, I think this is illustrated by these two blocks here. So these two blocks are sorry, I don't have a pointer, so I'm trying to get these my things. So made from the same material. So they should have the same density as Archimedes sort of worked out, which is the mass divided by the volume. But DEXA does not measure volumetric bone density, it measures areal bone density. So the mass is divided by the bone area. So here, the areal bone density of the big block is 6 grams per centimeter square, whereas for the small block, it is 4 grams per centimeter square. The volumetric density is identical, 2 grams per centimeter cubed. Now, you can substitute this, instead of having these blocks, you can put a small healthy child here, that's an 8-year-old, and a big 8-year-old child here. Even though they're completely healthy, you'll get totally different results. And herein lies the problem. So you cannot use areal bone density in a child without correcting for size. So size correction becomes very, very important. And so how do we do that? We actually, for the lumbar spine, we estimate and calculate what's known as lumbar spine bone mineral apparent density. So we assume that the vertebral bodies are like cubes. And there's a formula by Carter which is very easy to work out, and we get sort of very nice sort of normative data. These are from our normal LMS curves for our normative data. And you can do the same for the femoral neck. So by working out bone mineral apparent density, you are to some extent eliminating some of the size problems. But you still need to know whether your bones are slender or wide, because the size actually affects your bone mass, as I mentioned. So we use the Molgard's. So has somebody got a short bones? So if they're small, short, they will have short bones. And they got slender bones. So you look at bone area to see if the bone area is inappropriate for the height, which will give them slender bones. And then you see if they've got light bones. In other words, whether the bone envelopes are adequately filled with bone mineral content. So you look at bone mineral content and divide it by the bone area. So that's the Molgard. So here, this is the first step. So if somebody is short, if somebody is short, then obviously they've got short bones. And the second step is you look at bone area for height. And if they have got sort of low, then they've got slender bones, showing on the skeleton on the right. Or if they got high, they've got wide bones. And the last step is to see if the bone mineral content for bone area is low or high, which then gives you whether they got light bones or heavy bones. So by looking at this, you get some idea of other parameters other than the bone mineral content, which might be affecting the bone strength. And then, of course, the largest load on the bone comes not from standing or walking, but is by the muscle causing deformation. And here, this shows the muscle action causing deformation of the bones, and this in turn then stimulates the osteoblasts and the osteoclasts. So ideally, you should be able to look at the effect of muscle on bone, or the muscle-bone relationship. And because DEXA measures lean body mass, which is a surrogate measure for muscle, you can do that. So the way we do that is, first of all, ask if the patient has adequate muscle for height or lean body mass for height. If the answer is yes, then the next question that you do is to ask whether the bone mass is adequate for the muscle mass. If the answer for that is yes, then you've got a normal amount of muscle for your height and the normal amount of bone for your muscle, and you're a healthy child. Or you could have, sort of the normal amount of muscle for your height, but the amount of bone for your muscle is reduced, like in osteogenesis imperfecta, so you got a primary muscle defect. On the other hand, you may have less amount of muscle for your height, but the amount of bone for your muscle is adequate, like in Duchenne muscular dystrophy, which is the panel here. But majority of the time, we're dealing with chronic illnesses, and you got a bit of both. So you get reduced amount of lean body mass and the reduced amount of the bone for your muscle mass. So this again allows you to use the lean body mass that DEXA gives you, and gives you some insight into how this may be affecting the bone. And this is our Manchester bone density report, and we do all these measurements in this, and we also do QCT and PQCT, which I'm not going to talk about very much here. Now, because vertebral fractures are so important in the diagnosis of osteoporosis, looking for them is quite important. And these days, we actually do that by DEXA VFA, or vertebral fracture assessment, which Dr. Sabah mentioned. So here on the right panels, you have the standard radiographs here, and on the left, you have the DEXA VFA, and you can see that the DEXA VFA actually gives you much nicer images of the spine at really fraction of the radiation. So 200 microsieverts for standard radiographs, only 12 microsieverts for the DEXA VFA. So this is available at the point of care, and we do this very often, and it's more or less replaced doing the thing. So that's the background. Let's do a few examples. So Michael is a 9-year-old boy who has suffered 6 fragility fractures since the age of 2 years. Mother has suffered 27 fractures in her life. She's also suffered from joint dislocations. And there's a strong family history of fractures in his family, with maternal uncle and grandfather also being affected. In the past 4 years, Michael has been complaining of backache, for which he's been taking paracetamol and ibuprofen. So you all probably know what the diagnosis here is, but let's see what the DEXA values were. So I forgot to mention that in children, when you're doing the whole body bone density, you remove the head, because in small children, head is relatively large in relation to rest of the body, and the head may actually mask any small changes that you have in the rest of the body. So the subcranial BMC standard deviation score for Michael was minus 3, and the lumbar spine size adjusted, that's BMD, BMAD, was minus 3.2. So the next question is, does he have short, narrow, or long bones? So we do the Molgard for him. His height was minus 2, so he has got short bones. His subcranial bone area for height was minus 3.9, so he's got narrow bones. And his subcranial BMC, bone mineral content for bone area standard deviation score, was minus 2.9, so he's got light bones. So are these results due to primary or secondary muscle problems? So his lean body mass for his height was low, but not less than minus 2, which is the arbitrary cutoff. So not really, there is not such a big muscle problem. But the amount of bone mineral content for his lean body mass is reduced. So he has got probably enough muscle for his height, but that muscle is not making bone. So he's got a primary bone problem. So the interpretation of the DEXA is that he's got short, narrow, and unmineralized bones. He's got normal amount of lean body mass for his height, and he's got low bone mass for his muscle mass. Because of his backache, we did a spinal radiograph, and he had vertebral fractures, and the treatment for Michael is to optimize his vitamin D, ensure that he's getting adequate calcium intake, and because he's a boy with osteogenesis imperfecta, which you probably worked out from his history, we use compassionate use of IV bisphosphonates in children, which I'll talk in my second talk for that. I'm running out of time very quickly. Do I have 2 minutes to do one quick test? Thank you very much. So this is a boy with Duchenne muscular dystrophy, and the standard of care for boys with Duchenne is to put them on high doses of steroids so as to maintain their muscle function, to prevent scoliosis, and keep their heart healthy. And so George, basically at the age of 8 years, fell and broke his left ankle, and in the past, since then he's been a wheelchair user. In the past 3 months he's been complaining of backache, and for which he's been needing escalating doses of analgesics. So he had low subcranial total body BMC, and also low BMAD in his lumbar spine. He's very short because the steroids really almost kills the growth potential in this patient, so he's got short bones. He hasn't got narrow bones. He has got light bones because subcranial BMC for BMD was minus 2. Now, has he got reduced lean body mass for size? The answer is yes. Has he got reduced BMC for lean body mass? The answer is yes. So he's got a bit of a mixed picture here. Not the classical picture, but this is what you see in reality. The interpretation of the DEXA we've done, but at the age of 14 years, his pubertal assessment was really prepubertal, which is not an uncommon problem in boys with Duchenne muscular dystrophy because of chronic illness and treatment of steroids. And delayed puberty has a massive negative impact on the bone geometry. So if you look at in boys, if they have delayed puberty in the long bones, instead of becoming wider, they become very narrow, slightly less impact on the bone and the thing. So timely induction of puberty is very, very important. And because by 14 this boy had not started his things, we had sort of gave him 6 months course of testosterone, which in majority of these boys will kickstart their pubertal development. Sometimes they will need continuous testosterone treatment, but this is not an uncommon problem. So other bone densitometry techniques that we use in our pediatric practice, which I'm not going to use, is peripheral quantitative computer tomography, which is a standard sort of technique we use in Manchester, and we use quite a bit of quantitative computer tomography to look at the lumbar spine, trabecular bone mineral density, for certain situations, but I'm not going to talk about that. So to summarize my talk about DEXA was originally developed for adults. Children are not small adults. DEXA gives you aerial bone density, which is affected by size, and it's really, there's a major size component in it. Local normative data is very important, and different interpretation of the results. You know, you need to look at the estimated BMAD. You need separate assessment of bone size and mineralization to be assessed separately, and look at the muscle-bone relationship really is quite important. And you can do that with DEXA because you get your lean body mass, which is a surrogate measure for muscle. So with that, I thank you for listening to me.
Thank you.